And if, this patient can also cause, you may find irregular beat, atrial fibrillation, irregular beat, atrial fibrillation. Atrial fibrillation is one of the complications of left atrial enlargement. When left atrium is enlarging, the conduction defects will take place and you have atrial fibrillation. We have irregular rhythm. This irregular rhythm also can cause heart failure. So these are the auscultatory findings you should not miss. And when you go back and auscultate the lungs, you find the bilateral basal cryptations. So bilateral basal cryptations are one of the very important auscultatory findings in a patient who's got heart failure. So bilateral basal cryptations, usually we hear in patients who have heart failure, and right heart failure signs, as you know, AVP, tender hepatomegaly, and pedal edema. How will you and of course, other tests that you have to do is the ECG. Of course, you have to take. Sometimes ischemia can be the reason. If ischemia is the reason for heart failure, you may find ST elevations or TV inversions, ST depressions. So that is also a separate entity you have to treat. And if you do 2D echo, you may be able to detect if there is any valvular lesion, if there is any leaking of mitral stenosis, aortic stenosis, mitral regurgitation, or even if there is any regional wall motion abnormality, RWMA, regional wall motion abnormality. If RWMA is present, which means that this patient has a ischemic heart disease, coronary artery disease, which is causing heart failure. So establishing the underlying etiological cause in every heart failure patient is a must. Don't just say that it's heart failure and treatment. Always you have to find out what is the cause. Hello? 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 Is it coming? Yes. Okay. So we should make the patient sit 30 degrees or 45 degrees head up, because in this propped up position, patient will have less breathlessness. Because this patient may be having orthopnea, you should not allow them to lie down flat. Never, ever. As a rule, every patient in ICU should be made to lie down with little head up, 30 degrees at least. Even if they are not having a heart failure, you should always keep the head end of the patient bed up 30 degrees. But in heart failure, you have to completely, they can sit up 90 degrees or they can stoop onto the cardiac table also. So then every patient you must give oxygen, because there is a congestion in the lungs, there is a gas exchange defect is there, patient will have hypoxia. Even hypoxia is not there, you can give a low flow 2 to 3 liters of oxygen through nasal cannula or the face mask. And sometimes the patient may be in acute hypoxia, severe hypoxia, which you are not able to maintain with the nasal cannula. Then you have to give a non-invasive ventilator by BiPAP or CPAP or something like that. And in the treatment, the drugs, nitrates is very important. Nitrates you have to give NTG, which can reduce the pain and as well as dilate the coronary arteries. And then mainly you have to decongest the patient, because there is a congestion in the pulmonary system, there is a congestion in the peripheral part of the body. You have to give diuretics to take off the extra fluid that is accumulating. That is, loop diuretics is a good drug of choice. You can give 40 mg, 60 mg, 80 mg, up to 100 mg we can give, depending on the patient response. Then if the BP is not coming up, in spite of all these things, you may have to switch on to inotropic support, like dobutamine. Then you have to find out what is the underlying cause. This is acute setting. And beta blockers. Beta blockers once used to be, when we were students, they were in the books, they were mentioning that beta blockers are contraindicated in heart failure. But now, for last 20 or 25 years, we are using a small dose of beta blockers in heart failure also, that will reduce the heart rate a bit, and then the oxygen demand of this demand of the myocardium becomes little less. So educate the patient and try to find out what is underlying cause, and give diuretics and ACE inhibitors or ARBs are the cornerstone of the treatment. These will prevent the ventricular remodeling, further damage. This will definitely halt the progress of heart failure. The ACE inhibitors, ARBs are very useful, important and useful drugs. So ACE inhibitors, you know what is the mechanism of action. It will prevent the conversion of angiotensin 1 to angiotensin 2. And it also prevents the peripheral vasoconstriction, and it will reduce the salt and water retention, which will cause the symptoms. And another test, there are many tests like BNP. BNP is another very important test, brain natriuretic peptide. Brain natriuretic peptide, BNP. BNP is a hormone. BNP is secreted by the crying myocyte. When myocyte has some strain, I call it BNP as a sweating of the heart. BNP is a sweating of the heart. The more it is functioning, the more it is getting strained, the more BNP is released into the blood. When you do a blood test called BNP, if it is very elevated, more than normal, that's another marker of heart failure. BNP is a very good, excellent marker. So ultimately, there is no single test that will diagnose heart failure. Clinical examination, history, 2D echo finding, there's a subjective evidence, objective evidence of heart failure on 2D echo and BNP. So these three things are must, because there's no single, even BNP also can be falsely elevated in chronic kidney disease patient. BNP can be elevated in falsely elevated in, because BNP gets excreted in through the kidneys. So anybody has chronic kidney disease or any kidney related disease, the BNP excretion gets decreased. So BNP levels in the blood may go up. So that will give you false positive levels of high heart failure. So ultimately, everything put a heart failure diagnosis is not easy. Management also is not easy. The diagnosis depends on the history, 2D echo examination, typical history, clinical examination, and 2D echo for objective evidence, and BNP levels. The three jointly make the diagnosis of heart failure confirm. So that is a message you have to carry home. And beta blockers, as I told you, that's a drug of choice. But beta blockers we don't give, become little stable, but just before discharging, we give a very small dose of beta blocker. That is cardioselective beta blocker. Digoxin is another very important drug. Digoxin, it reduces the contractility. It reduces also the complication, the arrhythmias like tachycardia and atrial fibrillation. Digoxin also is very commonly used. Amiodarone is one of the anti-arrhythmic drug. It can be used in patients who have heart failure with arrhythmias like atrial fibrillation, supraventricular tachycardia. Amiodarone is a wonderful and very good commonly used anti-arrhythmic drug.